take up the medical issues now, the medical battle. I'm joined again from Canberra by Dr Peter Collignon, who's an infectious diseases physician and microbiologist with the Australian National University. Thanks for joining us again, Peter. Firstly, your reflection on the numbers, the flattening, if you like, of the growth in the infections, the encouraging sense that we could be pushing that curve down at the moment.
Well, I think it is encouraging that it does appear to be flattening. And in fact, if you look at the epidemic curve, it seems to be falling. Now, that's good, but we need to take into account that's probably measures we did 10 days ago, a week ago, everything from closing our borders to really quarantining all return travellers, following up cases. So my expectation is it will go down further because of those things we've done, and also all the social distancing that the vast majority of people have been following and are now even following more. The real issue is what is the underlying amount of disease or transmission that's occurring in the community that so far may have gone undetected. The reality is in Europe and the US, it must be fairly extensive because we had so many returning visitors that have had this infection in numbers, although in percentage maybe not as high. But what that actually means is their numbers go down, we then have to watch these others because that's a real concern. Now, the good news is still we relatively have found a lot more than other countries. We have got a lower mortality rate than other countries, or most other countries, which reflects we're doing more testing and finding more cases.
I've still got you there, Peter.
Sorry.
Actually, you mentioned mortality. I'll come back to that in a moment. But this is very important, these issues you've been raising now. Firstly, most of our infections have up until this point come from overseas, and our dramatic interventions there, including now the compulsory lockdown in hotels, will keep pushing that number down. But we have had community transmissions now, community infections, and with so many people asymptomatic, and obviously the government's ramping up efforts now, we must be very concerned that this is about to rise.
Well, I think it is a concern, but that's why the social distancing and physical distancing is so important. Because if 10 people give it to 15 people who give it to 18 people, you have an ever-rising epidemic. But if 10 people give it to 7 people who give it to 6 people who give it to 3 people, then it eventually, over a period of time, will disappear or become very low numbers. And hopefully, whatever we've got in the community here that's so far unrecognised, by these physical distancing, social isolation things were put into place, particularly protecting also those most at risk, which are people over the age of 70 or those with underlying conditions slightly younger than that. That actually both stops the spread, but also puts those most at risk at less risk of getting this and therefore getting really sick for it or dying from it.
So that is why right now, just when we're starting to see the first encouraging signs in the numbers, that is why the governments, state and federal and territory, are doing the right thing by saying this is not the time to ease off. This is the time to really ramp up that social distancing and try and prevent the community outbreaks.
Well, I think that's correct. I mean, we'll be wiser in a week or two's time when we see what the numbers do.
Yep.
But we've got to remember our most risky period is probably not now, it's winter.
Yep.
Winter is where most viruses, whatever they are, get transmitted more often. Maybe because of the dry air with heating, maybe because we're closer together. All those answers we don't know for lots of other viruses. But there's no doubt winter is much more of a risk than now. So the lower numbers we can get now, the better. But it also shows why this is a long-term issue. If we get a vaccine, it won't be for 18 months to 2 years' time. This is so widespread all around the world and possibly in Australia that we're not going to eliminate it. We're just going to be able to keep it down to low numbers, low levels of spread. So a lot of the things we're doing, maybe not quite to this extent in 6 months' time, but at least for quite a while, we're going to have to continue for many weeks, in fact, many months. Probably what we're doing now will have to continue till at least September.
Yeah, it's a critical point. You mentioned the fact that we're going into winter, going into the viral season, whereas in the Northern Hemisphere, it's the one advantage they've had, they've been coming out of it. I just want to go to that mortality issue and what we've learned from what's happened in the Northern Hemisphere, particularly Italy. So looking at this report from Oxford University looking at that. A couple of factors there. They look at the age profile of Italy and the number of smokers, especially men smoking, lifting their mortality rates. And they're also suggesting that just about everybody who died in Italy had secondary medical issues. Therefore, they're saying the mortality rate is increased artificially, if you like. Your thoughts on those studies?
Well, the studies I've seen coming from Italy, where they looked at the first 20% of people who died, 99% of those people had an underlying medical condition. Yep. So there's no doubt if you're over the age of 80, over the age of 70, your chances are much higher. Whether that's just a function of age or because at those ages you're more likely to have this is not entirely clear. But if ever you were going to give up smoking, now is a good time. And basically, those at more at risk need to physically distance themselves from more people at a higher degree, and that's particularly people over the age of 70. But we also have to be careful looking at mortality rates. Our rate here so far is much lower. In fact, if you look at the rate of death we have so far, even compared to South Korea, it's actually lower at this stage for the number of cases we get. You've got to be a bit careful looking at those figures in Australia because people often die 7 to 10 days after the onset of symptoms. So we may not be yet seeing the effect of infections now. That may be more apparent in 7 to 10 days' time.
Absolutely. But we should be looking to that to learn as much as we can. And one of the other factors they've focused on in Italy is the antibiotic resistance. Tell us about that and how that could be applicable to Australia.
Well, if we look back to 1918, the Spanish flu, what killed 80% of people or more was secondary bacterial infections, the pneumonia germ and a thing called group A strep. Effectively, that was an antibiotic-resistant bacteria because the antibiotics weren't there. So a big cause in the past, in our major epidemic 100 years ago, was bacterial second infections. The situation we have now is there's lots of countries with lots of superbugs that flow through waterways, etc., and get to people. China being a good example. Italy has a much higher superbug rate than, for instance, Sweden or Norway, and a much higher rate than us here. And from data I've seen, quite a number of these people who die in intensive care units, for at least a few days before they die, have superbugs causing secondary infections. Now, whether that, again, is cause and effect, we don't know yet, but it's a bit suspicious. And again, another reason to actually be a bit careful about how we interpret mortality rates. If I go back to swine flu, for instance, if you look at the hospital rates, even in Australia, the death rate or mortality rate was 3 or 6%. But when we finally got the figures in, because it was so widespread in the community, the mortality rate overall in the community was only 0.02%. Now, I don't think this mortality rate's going to be as low as this. I think it's at least 10 times higher, but it may well end up being about 0.2, 0.3% once we identify how many are in the community. That's good and bad. If we have a lower mortality rate, everybody says, oh, that's a relief. But the bad bit of it is that actually means it's gone much further in communities all over the world than we realised. We'll actually know that once we have what we call a serology or antibody test available. Yep. We can say, oh, look, this group had 10 people we diagnosed, but they were a group of 200. And when we did blood tests, we found, oh, it wasn't only 10 that had it, it was another 30. And that tells us what the spread's like. Now, that will become available, I would think, in the next month or two, and that'll give us a better idea on how much this actually transmits and to who, how many are asymptomatic, and what the true mortality rate is in different age groups, because it'll be quite different in 30-year-olds compared to 80-year-olds.
Dr. Peter Collignon, thanks so much for joining us again.